Okay, thanks so much for joining us. Today we have Dr. Benjamin Nwosu. He's an MD, professor of pediatrics at the Zucker School of Medicine at Hofstra Northwell, New York. He's a chief of endocrinology at the Cohen Children's Medical Center as well. And just a little bio about him. He's a global expert on the partial clinical remission phase of type 1 diabetes, also known as the honeymoon phase. He holds the IND for vitamin D supplementation to prolong the honeymoon phase of type 1 diabetes. And his recent article in JAMA was the first to show that high dose vitamin D could prolong the honeymoon phase of type 1 diabetes. Prolonging the honeymoon phase of type 1 diabetes reduces the long-term complications of the disease, and his research publications on diabetes and general endocrinology have been extensively covered in the media. He recently received a research prize from the American Diabetes Association, has been recognized as one of the top endocrinologists in the country by Castle, Connolly, and Markey, who's who. He serves on the editorial board of several scientific journals and sits on several NIH study sections. He earned his medical degree from University of Nigeria and completed his residency training at Howard University Hospital in Washington, D.C., obtaining his fellowship training in endocrinology at NIH in Maryland. We're going to take questions at the end, and I'm going to drop his recent paper in the chat. And thank you so much, Dr. Nwosu, for joining us.
Thank you so much, Dr. Wesley. Thank you so much for inviting me to speak on this national and international forum. And I have nothing to disclose. The topic of our presentation is vitamin D and type 1 diabetes. I received grant from the National Institutes of Health for this work. So we're going to introduce the topic, look at a few ways vitamin D interact with diseases, and then type 1 diabetes, and then we will conclude. So this is the paper that we are going to be talking about. But before we get into this paper, let's talk about vitamin D. This lecture is really about how science investigates natural phenomena. In this case, the curious case of vitamin D and type 1 diabetes. So vitamin D is also known as the sunshine vitamin. So when the UV radiation from the sun hits our skin, it starts a process called photolysis, which is similar to photosynthesis in plants. So it converts 7-dehydrocholesterol to pre-vitamin D by opening up this B carbon ring and then converts it to a steroid. Pre-vitamin D is very, very unstable. So under the heat, under the skin, it undergoes another process called thermal isomerization. And then this converts it to vitamin D, which is then transported to the liver, where it is hydroxylated at the 25 position right here to form 25-hydroxy vitamin D, which is a stable product. And it is the marker of either vitamin D sufficiency or deficiency. Now, when the body needs vitamin D activity, this 25-OHD is transported to the kidneys, and there it is further hydroxylated at the 1 position to form 1,25-dihydroxy vitamin D, which is also known as calcitriol, and that is the active form of vitamin D. So I put up 2 questions here to help us frame this discussion. Can vitamin D excess result from excessive sun exposure? The answer is no, because once the body makes enough 25-hydroxy vitamin D, then it begins to convert further products to an inert compound called lumistrol. The second question is, does one need to be under the sun for hours to get adequate vitamin D? The answer is no, because this process of thermal isomerization continues long after the individual has left the area of sun exposure. Vitamin D is so vital that its deficiency can occur from birth to elderly stage of life. So if a mother has low vitamin D state, certain things happen to the fetus. There are things that are called epigenetic modifications, which can occur through the process of DNA methylation or histone modification, which then will trigger intrauterine biological programming in the fetus that will have serious consequences later on in life. In this case, we are talking about type 1 diabetes, and we're going to show how these things happen. So this is an interesting slide showing the incidence of type 1 diabetes around the world. As you can see from this slide, if you live in the equator, you have very low incidence of type 1 diabetes. But as you move to the northern latitudes, like Sweden, like Finland, you begin to have increased incidence. And I put up this sunshine cartoon here and road tropics here. And the question then is, why is it that we have lower incidences in the tropics and then higher interest in incidences in the temperate regions? Is it because of sun exposure? Has it got anything to do with vitamin D? So we're going to be answering all these questions. Along with type 1 diabetes, multiple sclerosis also shows similar distribution. So is there a link between low vitamin D and high prevalence of type 1 diabetes in Finland, for example? Talking about Finland, there was a study published this year that was covered by Medscape, where they showed that low vitamin D during childhood is significantly associated with increased risk for adult onset atherosclerotic cardiovascular disease. This is important as we're going to talk about lipids down the road. So this study was published this March, covered in Medscape. It's a study where they use high-dose vitamin D to reduce disease activity in patients with multiple sclerosis. This was conducted in France. A well-designed randomized control trial using high-dose vitamin D, 100,000 international units every 2 weeks for 2 years. And they found a positive outcome at the end. This survival curve shows that those who receive vitamin D fared better than those who receive placebo. So once you see this kind of picture, you ask yourself, what of the type 1 diabetes? These French researchers have shown an important outcome for multiple sclerosis. What of type 1 diabetes? So we're going to talk about that soon. Studies that were published at the turn of the century show that individuals with type 1 diabetes have low levels of vitamin D, okay? And nobody has been able to explain it well up till now. And they also show that in adult patients who are treated with higher levels of vitamin D, they have reduced immune attack on the beta cells. And then in children who have higher levels of vitamin D, they have also lower levels of autoimmune attack and risks. And then those who are treated with vitamin D also showed increased capacity of regulatory T cells. These are good T cells. And this paper was just published this year, showing that vitamin D is not just a vitamin, it's an immunomodulator. So it helps to maintain our immune system. And we are really interested in what it does to the pro-inflammatory cytokines, such as tumor necrosis factor alpha, which I put something around here. And also how it improves anti-inflammatory cytokines, such as interleukin 10. So I summarized the activities of vitamin D and the immune system using what's called the vitamin D protection triad. It reduces inflammatory cytokines, it increases regulatory cytokines, and also reduces systemic inflammation. These are some studies that have been published since the turn of the century, looking at vitamin D. And what is common about these studies is that they do have positive signals, but they mostly use lower doses of vitamin D. And continuing on to our publication in 2022, though our 2024 publication wasn't included in this list, but we're going to talk about that. Interestingly, people like Dr. Pinheiro in Brazil have combined vitamin D with other agents to see if that augmented its effect. And they got positive results too. So in 2012, Gabe and her colleagues published this paper in JAMA Pediatrics, where they conducted a randomized control trial using 2,000 international units of vitamin D daily over an 18-month period. They showed that, yes, vitamin D improved the immunological profile of those patients who received vitamin D. And there was also a preservation of beta cell function amongst those who received vitamin D. And they thought that this could position vitamin D as a therapy in the future. So that was 2012. Then in 2015, Mishra and colleagues from India published just a short-term study, 6 month, randomized control trial of vitamin D. Again, they used 2,000 international units daily, so low dose. They did not see any significant difference in their outcomes, but they showed some positive signals that could point to some activity that have not been shown because maybe they used the lower dose. So our group came in 2022 with high dose protocol, 50,000 international units per week, in a randomized controlled trial of vitamin D in children with newly diagnosed type 1 diabetes. Now, before we get to that study, let's talk about what diabetes is and what honeymoon period is, and then how high dose vitamin D could impact autoimmune disorders. We're going to be very specific. We're going to talk about where, when, how, what, and who. That way, we provide a comprehensive answer to this question. So, vitamin D acts on the honeymoon phase of type 1 diabetes. As most people know, type 1 diabetes is now divided into stages from stage 1 to stage 2, and then stage 3A is when the diagnosis is made. And after that, there's a honeymoon period in some cases called stage 3B, and then stage 3C is established type 1 diabetes. So honeymoon period is usually referred to as a transitory period of partial clinical remission following the introduction of insulin therapy. So when you begin to treat patients with insulin, those surviving beta cells will get some rest, and then they will begin to recover and produce insulin and C-peptide. More importantly, it's a critical stage where investigators can introduce new diets, immunotherapies, and other strategies like high-dose vitamin D to expand the beta cell mass, or even allow for formation of new beta cells in a process called beta cell neogenesis. But why is the honeymoon period very important? This is because the longer the honeymoon period, the better the outcome for the patients, because it diminishes the risk for long-term complications. And it does this through two mechanisms. One is reduction of glucotoxicity, and two is reduction of lipotoxicity. Most people talk about glucose, but few people talk about lipids because it's difficult to study lipids than glucose. But luckily for us, I'm going to talk about lipids as well. So this is going to be a full lecture. Now, there's a little bit of lack of consensus on the gold standard criterion for the definition of partial remission. American Diabetes Association uses stimulated C-peptide concentration. Now, this is a static definition because it just shows a level at a point in time. So more and more organizations are moving away from it into functional definitions, one of which is the insulin dose adjusted A1C. Insulin dose adjusted A1C level of less than 9 or 9 will be consistent with remission. Now, if somebody is using serum C-peptide level, a fasting level of more than 0.1 nanomole per liter or a 2-hour post-meal level of 0.2 nanomole per liter will be sufficient to define partial remission. So we've been talking about C-peptide for some time. What is C-peptide? So C-peptide is also known as connecting peptide. It is secreted at the same time with insulin. Now, it's a very special polypeptide. It consists of 31 amino acid, and then it does not have a receptor. So it signals through intermediary chemokines, but it has important activities. It reduces the level of inflammatory cytokines, such as TNF-alpha, tumor necrosis factor alpha, which we're going to talk about down the road. It also maintains vascular integrity. More importantly, it has a much longer half-life than insulin. Its half-life is 31 minutes. Insulin's half-life is 4 minutes. As a result, it's used as a marker of endogenous insulin production. Not every child who is diagnosed with type 1 diabetes would undergo partial clinical remission or honeymoon phase. Only about 65% of children with newly diagnosed type 1 would undergo partial remission. We began this journey in research in partial remission at the University of Massachusetts in 2017, when we published our first paper in PLOS ONE, where we showed that partial remission peaks around 6 months following the diagnosis of type 1 diabetes. It is more robust in boys than girls. We also showed that there are 4 clinical factors that could predict who would not experience partial remission. These will include high levels of low bicarbonate levels consistent with high acidosis, younger age, female sex, and the multiple autoantibodies in serum. So let's say a few words about lipids, which people don't really like to talk about, but it's a big player in partial remission. And the research question is, does the honeymoon phase impact lipid profile in children? So what we did here was to follow a group of children 5 years after they have been diagnosed with type 1 diabetes. And then we stratified them based on body weight into normal weight and overweight obese. We showed that those who underwent remission had significantly lower levels of LDL cholesterol when compared to those who did not remit, suggesting that vitamin D protects against obesity-related dyslipidemia. We looked at these youngsters as they were going through puberty as well, and we found that those who underwent remission also had significantly lower levels of LDL cholesterol compared to their peers who did not remit. And while we were doing this, we knocked off a study that was published in 2000 that claimed that every child with diabetes had hypercholesterolemia. That's not true. The truth is that if those who underwent remission had normal lipid profile, it's those who did not remit that had high levels of lipids. So by end of 2019, we had established a few things: a predictive model for non-remission, how to monitor partial remission, and also that there are consequences to lack of remission in terms of early appearance of dyslipidemia. Then we were like, what of adults? Are we able to establish this same dichotomy in lipid profile in adult patients with type 1 diabetes? So we published this paper in 2021 showing that yes, partial remission reduces lipid-based cardiovascular risk in adult patients with type 1. So what we did was we had 4 groups: a control group, remitters, non-remitters, and patients with type 2 diabetes, who also served as a second control arm. So we use factor analysis and 2-dimensional graph to represent this, essentially showing that the mean composite scores of lipid parameters of those who were the control subjects and those who remitted were in the lower risk quadrant, whereas those who did not experience remission looked more like the patients with type 2 diabetes, who usually have worse lipid profile. So this tells you that even though type 1 diabetes is one disease entity, there are several endotypes, in this case determined by presence or absence of partial remission. And this will determine who will go on to have severe long-term complications. So then I moved to New York in 2022. And then the question was, with all the data I had, can we create a unifying theory of cardiovascular disease risk based on partial remission across the lifespan in children, adolescents, and adults? Is there something that can unite cardiovascular risk and help us to identify those who are at risk? But the key question, though, is why is a lipid-based theory important? Well, it is important because glycemia offers only a partial explanation of cardiovascular risk. So even with tight glucose control, type 1 still has a high degree of morbidity and mortality, 5 times higher cardiovascular risk, and reduction in life expectancy of about 12 years. So there's a missing link. Something is not adding up. So this figure takes us through 5-year worth of work from preclinical type 1 diabetes to those factors I mentioned that will determine who will experience remission or not. Those who go on to experience remission go on to have a good metabolic control. as a result of what is called metabolic memory. So the body remembers all the events that happened around the time when the diagnosis was made. Now, those who did not experience remission go on to have poor metabolic control. And up until the publication of this work, people believed it was as a result of hyperglycemic memory, right, which will lead to abnormal blood glucose levels. But if it were so, then it would explain only the small vessel complications of diabetes, the microvascular complications. It will not explain the lipid-based large vessel complications. So that was where my theory came in, called the hyperlipidemic memory theory, to show that this lipidemia is a big player in this whole theoretical framework. So this was published in 2022. So now let's come to back to vitamin D and type 1 diabetes. Can we intervene to prolong partial remission? So we conducted this randomized control trial. This is our consult flow diagram, which you have to publish along with a randomized control trial. So we enrolled 48 subjects, randomized 36 of them. 18 subjects received high-dose vitamin D, 50,000 international units weekly for 2 months, and then every other week for 10 months. And the other group received placebo. And we followed them for 1 year and analyzed our data based on intent to treat principle. So we showed that those who received vitamin D had higher levels of 25 hydroxyvitamin D throughout the study duration. We also found that those who received vitamin D had significantly lower levels of tumor necrosis factor alpha compared to the placebo, suggesting that vitamin D had anti-inflammatory activity by decreasing this pro-inflammatory cytokine. We showed that those who received vitamin D had a slower rise in their hemoglobin A1C compared to the placebo, where the rise was sharper, which is a good thing for those who receive vitamin D. And then it showed that those who receive vitamin D also had a slower rise in their insulin dose adjusted A1C compared to the placebo, suggesting that vitamin D was prolonging the honeymoon phase, which is also a good thing. So we published this in 2021 in the Journal of the Endocrine Society. And right after that publication, I began to receive a lot of emails and contacts through LinkedIn from parents, doctors treating newly diagnosed patients with type 1 diabetes, asking for guidance on how to dose vitamin D in these subjects. I thought I was just going to be responding to them and, that would be all, but it kept getting, more intense. So one doctor from California asked me, can't you write a guidance on this thing? I said, okay, I'll write a guidance on it. So I published the guidance for high-dose vitamin D supplementation to prolong the honeymoon phase in children with new onset type 1 in 2022. And this is the protocol. So when a child is diagnosed with type 1 diabetes, amongst other things, measure the 25 hydroxyvitamin D level. If it is less than 30 nanogram per ml, initiate vitamin D supplementation using either vitamin D2 or D3 to maintain the level between 30 to 60 nanogram per ml. If it's above 30, then you can monitor the 25 OHD levels. And then if it drops below 30, you can then initiate supplementation. So in 2024, we moved from glycemic endpoints to beta cell physiology because we wanted to find out exactly what was going on. How is the sun controlling the incidence of type 1 diabetes around the globe? And then even our findings, how can we really explain what we found? Because we are not able to explain what we found, then we have not really touched the molecule. And so we still needed to do more work. So we went back to our friend, C-peptide, and just a little explanation about how this thing works. So before you can have insulin, you have to break down this bigger polypeptide called pre-proinsulin, cleave it, and then you move to the stage called proinsulin, which contains insulin and C-peptide. This is an important step. If beta cells are under stress, the proinsulin level will accumulate within the beta cells. And then if nothing is done, they go on to die. But if something relieves them of that stress, they will live longer and continue to make insulin and C-peptide. So vitamin D helped to promote this very step. And let me just show you a few things about vitamin D and cellular health. There was a study published this year on May 21, 2025 by the Harvard group led by Dr. Joan Manson, where they conducted a 4-year randomized control trial of adult patients who received 2,000 international units of vitamin D or placebo. And they found that vitamin D slowed down the erosion of telomeres. You know, I did my fellowship, part of my fellowship on telomere shortening with aging, and telomeres are biological clocks. If your telomere is intact, you will live longer than the individual whose telomere is shortening at a faster clip. So what they did was they randomized 508 individuals to receive vitamin D3 and another 523 to receive placebo. And they had a secondary arm where they randomized 514 subjects to receive omega-3 fatty acids, and then another 517 to receive placebo. And then they followed them out for 4 years and measured their telomere length. So they found that vitamin D supplementation significantly preserved telomere length compared to the placebo. And they did not find the same thing in those who received omega-3 fatty acid compared to placebo. So in a way, what this study is showing is that vitamin D actually protects us from cellular apoptosis. And with adequate amounts of vitamin D, we can live longer than people with vitamin D deficiency states. So we come back to this, our slide. And if you understand what I just said a few slides ago, you see that vitamin D essentially reduces apoptosis of beta cells by decreasing the PIC ratio, proinsulin to C-peptide ratio. And this is probably one of the reasons why this was published in JAMA. So one of the figures in our paper shows that those who received placebo started at a huge advantage. Their PIC ratio was actually lower than those who received vitamin D, but they quickly lost that advantage within 3 months. And they went on to have high levels of PIC ratio over 12 months, suggesting that their beta cells were not protected from beta cell endoplasmic reticulum stress, whereas those who received vitamin D were protected. So this is the holy grail of research in beta cell health. You have to demonstrate this lowering of PIC ratio. We also showed that those who received vitamin D had a slower decline in the loss of C-peptide over time compared to those who received placebo, where the loss was much steeper. So this paper was published, received a lot of attention, both in the Endocrine Society and elsewhere. It was covered by Medscape, so we beat the French team by a year, and this race to the sun. And we interviewed in New York, received awards. This was featured in the American Diabetes Association Thought Leader Series last year at the ADA conference. And our results have continued to be supported by newer trials that were published this year. The Poseidon study, which was led by Dr. Ricciotti from Florida, showing that patients who had higher fasting C-peptide levels had better outcome than those who had lower. And fasting C-peptide correlated positively with vitamin D at baseline. So has this research actually impacted patient care? The answer is yes. We have what's called the honeymoon clinic here at Cohen Children's, where people who are diagnosed with new onset type 1 diabetes can opt to receive vitamin D if they wish. And then we track them across the year. We have papers being published and projects going on by our colleagues here in the division. And we have this interesting paper that is under review, where a family that stuck to the protocol to the letter showed that their child who has type 1 diabetes maintained normal A1C level for 2 years and a low total daily dose of insulin for 2 years, and insulin dose adjusted A1C is still below 9 for 2 years. This is not here in our institution. This is somewhere in the South. So but they're collaborating with us for the publication. We do receive cards from families that are very grateful about vitamin D supplementation. And this is how you can get vitamin D easily through your diet. So we are back to our slide of the global incidence of type 1 diabetes. So I hope that we have now answered this question posed by Nature on why type 1 diabetes is more prevalent in the temperate regions compared to the tropics. And then another question then is, can we flatten the U-shaped curve of global incidence of type 1 diabetes? It's possible to flatten this curve because if you orient the sun to shine more in the temperate region, I'm sure that this will flatten because the vitamin D, they will get vitamin D all year round. Now, another thing you can do is to supplement them with vitamin D at a higher 25 OHD benchmark, and that will help reduce that high prevalences. It takes a village to raise a child. It takes a village to do this kind of research. I'm very grateful to my family, my wife and children, and to all these people listed here who have continued to help and with our research, and to National Institutes of Health for sponsoring this research, and all the media houses that have continued to publicize our work. My division and the children who took part in this research. Despite the painful needle sticks and all the things we had asked them to do, but I'm very grateful. Thank you, everyone.
Thank you, Ben. It's a great talk. We have some questions in the chat already, and so I'll read them. So for those listeners, so from, let's see, dear Marcelo, could serum vitamin D levels between 40 and 60 nanograms per milliliters be more useful to maintain PR?
Yes, Marcelo. So Dr. Marcelo Pinheiro is from Brazil, and he's hosting a conference on Saturday where I will also be lecturing. Yes, when I was writing my paper, I wanted to actually go as high as 80, but the reviewers will not let me publish it. So I kept it at 30 to 60. But I agree with you. In fact, the true believers actually keep it between 50 and 100 nanogram per ml. So the answer is yes.
Okay, great. From Alexis Carmer, in your clinical protocol for vitamin D supplementation, is dosing guided by serum levels?
Thank you. So we were the first group to actually use high dose vitamin D, and I can tell you, my institutional review board and the FDA, they were always asking me what's going on with those children. You know, is anybody's experiencing side effects and so on. It was not, because if you can see, there's one of those early slides, we did not even hit those high levels, right? So we maintained on the standard a priori protocol doses. We did not decrease anything, but it's a good question because we could have increased the doses to hit those high marks.
Okay, Dolly Cajero. Thank you, Ben, for this brilliant lecture. Why is partial remission more robust in boys than compared to girls? I guess if you have a hypothesis there.
Okay, so in research, there's always this thing called the heterogeneity of response, which sometimes we will never understand it, right? It could be because girls have a little bit more body fat mass, right? And that would translate to increased insulin resistance. and boys have more muscle mass, translating to reduced insulin resistance. And these things play a role. My sense is that it has to do with that difference in insulin resistance states between the two sexes.
Okay. Congratulations. People are leaving and saying great talk. I guess, oh, here's another one. Being that vitamin D has inflammatory, hold on. Anti-inflammatory cytokine, would it be very effective in controlling other autoimmune conditions? I think you did speak about MS, but I don't know if you want to extrapolate further.
Yeah, that is true. Vitamin D is really a super molecule, even though it's free, and we don't really think much about it. But think about vitamin D. Vitamin D is the only substance in nature that can mineralize bones. So the reason we can sit, stand, walk, and run is because of vitamin D. And also, its anti-inflammatory properties is also a contributing factor to what we are seeing in autoimmune conditions.
How does here's another one, from a tropical region with higher natural vitamin D synthesis to a temperate zone affect baseline 5-hydroxyvitamin D levels in kids and adults? Should vitamin D levels be checked before relocation to anticipate potential drops? And how quickly does vitamin D status decline after reduced sun exposure? We talked a little bit about this offline before the talk, that the data from those moving from tropical climates to temperate climates, have been shown to be have more risk for type 1 diabetes. Sorry, I'm still letting people in and doing all these other things, but yeah, how would you answer those questions?
Absolutely. If I had done when I was moving to America, I would have checked my vitamin D in Nigeria to see where things are now. But absolutely, it drops once you get into the temperate climate because you're not getting intense solar, what we call isolation. And then at the same time, it's not all year round. So in temperate climates, vitamin D rises during the summer months and then it drops during the winter months, right? So we rely on supplementation. Now, for somebody living in the tropics, though, if you're an office worker and you go to office in the morning, stay in the office throughout the day, and go home in the evening, you may not be getting enough sunshine. So your vitamin D might also be low, even though you live in the tropics. Oh,
Yeah,
sorry. There's no way to measure, and then go and check. Just when you are landing your new area, you can just monitor your vitamin D over there.
yeah. Wonderful presentation. Does this research relate to adults with type 2?
Yes. So that's important. So in my lecture last week, I talked about extraskeletal health. So my friend at Tufts University in Boston, Dr. Peters Anastasios, ran the D2D study where they showed that, yes, optimal vitamin D, the one decreases the risk from progression from pre-diabetes to type 2 diabetes. So it's the same protection of the beta cells that we see too. And people with type 2 diabetes should also take vitamin D because you're helping those cells to work better.
I have another question. Are the high doses of vitamin D intake contraindicated?
No, no, they're not contraindicated. We were just talking about this before the talk that you will show me up to 5 papers that has reported clean data on vitamin D toxicity. You will not be able to show me that. It's so rare. And people who report toxicity, they are doing something crazy. They may take 50 pills and just, run around claiming that they have vitamin D toxicity. So if you're in the temperate region, you should be on supplementation.
I guess I would like to ask you a question, in terms of kind of refining the treatment plan for those that are at risk for type 1 diabetes, are you currently looking into those windows prior to diagnosis, prior to establishment of honeymoon? If someone has a genetic risk or if they are stage 1, how are you working to, study this closer as to whether or not vitamin D is impactful in those settings?
Absolutely. So At my lecture last week, somebody said that from another institution was saying that they have patients with stage 2 type 1 diabetes who have declined to go on teplizumab infusion, right? And so they started those patients on high dose vitamin D. Now, after I heard that, I was like, tell me more, because we actually want to publish that because from the data the individual shared with me later on, it showed that they are seeing some positive signals. Okay, so vitamin D, even though I'm focusing on the partial clinical remission phase, is something that happens across the cycle of type 1 diabetes from stage 1 to 3C.
And then I guess, you guys have, you highlighted the fact that you have a honeymoon clinic at the Cohen Clinic in New York City. That sounds like a really good idea. How might you expand that knowledge to other clinical settings and institutions, or replicate it really?
Yeah, I mean, it's through things like this. Thank you for inviting me to give this international lecture, because this is how people will learn about what's going on here and elsewhere. However, the patient I showed the paper that is under review, that patient was is being followed at Emory University, you know? So people are asking for this, and people who call me during the at the time of diagnosis of type 1 diabetes or family member or something, they go ahead and present my paper to their doctors and say, why are we not, being offered this therapy if they have not been offered? So it's word of mouth, it's the media, it's also special platforms like yours.
Yeah. Well, we are hoping to reach more of the general practitioners as well, outside of the sort of endocrinology focused realm, so that they have this in their toolkit as well. Um, the latest and greatest in the clinical sphere. So,
Mhm.
one last question: How, from Dr. Miyajeki, how does vitamin D status affect insulin sensitivity in adipose tissue, liver, and muscle? Are improvements in insulin sensitivity after vitamin D supplementation due to direct effects on insulin receptors or indirect effects? An example, reduced inflammation. And can improving insulin sensitivity via vitamin D or otherwise reverse this pattern, promoting fat oxidation with respect to visceral fat metabolism instead? Three questions, really.
Yes, I mean, so many things there. But if you remember one of those few slides I showed, that the impact of vitamin D deficiency runs from cradle to grave, essentially. And Dr. Peters and Astesios, through the D2D trial, showed that yes, vitamin D could reduce insulin resistance. And then there are vitamin D receptors on the beta cells. In fact, vitamin D receptors are all over the body. There's nothing like vitamin D, I think, in human biology, because it's the same process that plants use to generate their own energy that we use to generate vitamin D. And so I don't think we can survive on the planet without vitamin D. Um, so most of those functions, from insulin resistant state, um, reduction in adiposity, anti-inflammatory properties, are all there for vitamin D. It depends on where you are looking, and when you write a grant, they will say, give us 3 M's, and so you limit yourself. But as more people are looking at this with using high dose vitamin D, they are going to be clearly demonstrating those pathways.
Okay, well, this looks very interesting. So, thank yous in the chats, and I will, we'll be posting this in our video library very soon. And also, thanks to you to raising this important conversation, and we look forward to more papers and studies and developing, coming from your corner of the States. Thank you again, and have a great rest of your day.
Thank you so much.